very excited about today. Okay, it says it's recording on my end. You guys might have gotten a notification. Fantastic. All right, well, welcome everyone. I am excited and honored to introduce today's speaker for our monthly NETChatter event. Here today we have Dr. Will Pegna. He is a medical oncologist at the medical oncology lead for the OHSU Knight Cancer Institute Multidisciplinary Neuroendocrine Tumor Clinic. He is actively involved in clinical trials and cancer research to improve the survival and quality of life for cancer patients, and to also better understand the biology of these diseases. In addition to neuroendocrine tumors, Dr. Pegna is interested and experienced in the management of other GI cancers and rare tumors, including pheochromocytomas, paragangliomas, adrenocortical carcinomas. He specializes in the use of chemotherapy, immunotherapy, and multidisciplinary approaches to cancer care. Dr. Pegna finds it rewarding to help patients understand their disease, providing treatment options based on the individual patient, and supporting them through their treatment journeys. In addition to his work in the clinic, he enjoys teaching medical learners at all levels, patient advocacy and education, which we're happy to have him here today, and he's involved in regional as well as national neuroendocrine tumor-focused committees and cooperative research groups. He grew up in upstate New York in a French-speaking family and goes by, Will, you're going to have to pronounce the name so I don't butcher it. I should have asked you first.
That's okay. It's Guillaume or Will or anything that comes easily. So
Thank you. And although he spent most of his life on the East Coast, Dr. Pegna, along with his wife and children, are very excited to now call Portland home. When did you move to Portland?
2021.
2021. Okay, excellent. Well, thank you so much for speaking to our group today. We're very excited to hear from you and the high-grade neuroendocrine carcinoma.
Thank you so much for the introduction. Let me share my screen. Why am I not finding it? Share screen, there it is. Okay. Is my presentation up here?
Yeah, looking good.
Great. I apologize if occasionally I have to stop and cough or take a drink. I have very young children, so I'm in a persistent state of having a cold or convalescing from a cold or somewhere in between. But it is really my pleasure to be joining you all today and to have the chance to talk about the management of high-grade neuroendocrine neoplasms. There we go. So objective of the talk today, to start off going over the classification of high-grade neuroendocrine neoplasias, including neuroendocrine tumors, neuroendocrine carcinomas, reviewing the current management paradigm for neuroendocrine carcinomas, as well as emerging drug targets, to review the management paradigm for high-grade neuroendocrine tumors, and then discuss current challenges in the existing classification scheme, as well as the management of neuroendocrine neoplasias. So going into the basics here of high-grade neuroendocrine neoplasms, in a lot of talks, this is the part that I would go over what is a neuroendocrine tumor, but given the audience, I'll skip over that and go over some of the overarching basics of the talk that I'll be doing today. So our focus here specifically when discussing about neuroendocrine carcinomas are on extrapulmonary neuroendocrine carcinomas, omitting small cell lung cancer, Merkel cell carcinoma, which although histologically and biologically related are really different diseases. Data that is presented here, first of all, it's very limited because this is a very rare disease entity. Most of it is retrospective unless it's otherwise specified, which I will specifically let know in that case. So looking at the evolution of neuroendocrine neoplasm classification, really 2010 WHO, the grading scheme split things into three groups: the grade 1, grade 2, grade 3, both by Chi-67 index, grade 1 less than 3%, grade 2 3 to 20%, grade 3 greater than 20% Chi-67 index, and then saying that all grade 1s and grade 2s are well differentiated and all grade 3s are poorly differentiated. Now, this, although helpful in terms of understanding patients who have widely different outcomes, did leave a little bit of a hole that was unexplained here. This specifically well-differentiated Chi-67 index greater than 20% population, which were noted to really behave differently than the poorly differentiated neuroendocrine carcinomas, but also behave more aggressively than the grade 1 and grade 2s. And so this came to head, and I should say this is really a GEP-NET classification scheme, but it tends to be used across neuroendocrine tumors at this point. This goes into making now three categories, three grades of well-differentiated neuroendocrine tumors, grade 1, 2, and 3, with this new group of well-differentiated Chi-67 index greater than 20% being a grade 3, and poorly differentiated neuroendocrine carcinomas having any Chi-67 index. These are about evenly split between large cell and small cell. As I see a lot of GI-based neuroendocrine carcinomas, it tends to be more on the large cell side of things, whereas if you are including more pulmonary disease, small cell is much more common as well. Now, this is a really important separation being made of grade 3 neuroendocrine tumor versus neuroendocrine carcinoma, as they are prognostically very different diseases. So this is a Kaplan-Meier curve of cumulative overall survival from the time of metastasis from a study back in 2021 in neuroendocrinology. What you can see is that the survival from the time of metastasis for neuroendocrine tumors grade 3 is really approaching almost 3 years, whereas for neuroendocrine carcinoma, regardless of the Chi-67 index, it's much more what we classically counsel patients in the 12, potentially more modern data saying 18 months, but really a fraction of the survival of grade 3 neuroendocrine tumors. And so these are really distinct diseases. When we go into the epidemiology of both grade 3 and neuroendocrine tumors, as well as neuroendocrine carcinoma, really this is a difficult subject to go into just because these are very rare diseases. For grade 3 neuroendocrine tumors, incidence is really unknown. Most registries internationally do not collect information on grade, at least they have not historically. They are estimated to be approximately 10 to 15% of neuroendocrine tumors, potentially higher with certain primary disease sites. But this is a disease where the prevalence is greater than the incidence, than the yearly incidence. And this is because patients can survive a long time with this disease. Neuroendocrine carcinomas, largely unknown from a histology-specific subtype. If you're saying all patients with neuroendocrine carcinoma, we do know that this is a very rare disease. When you're going into more specifics, like colorectal neuroendocrine carcinomas, its estimated incidence of 0.2 per 100,000 inhabitants in the United States yearly. This is a disease where incidence is probably close to prevalence, if not a little bit higher, just because the survival tends to be so much shorter. Looking at sites of disease, this is a illustration from the University of Iowa, perhaps a little bit dated now, but it gives a good sense a little bit of, for grade 1 through 3 neuroendocrine tumors, the primary sites of disease. Small intestine is very well represented, pancreas, lung as well. I think nowadays some trends that have been noticed and that we see much more of, gastric neuroendocrine tumors having a much higher incidence, being recognized more often, rectal as well. But still kind of giving a sense that this midgut region is the really where we see the most neuroendocrine tumors. Now, I can't say that for grade 3, this matches this proportion exactly, but we're still kind of looking in the neuroendocrine tumor side of things in terms of sites of disease. When it comes to neuroendocrine carcinoma, this was a really great in cancer back in 2018. So when you include small cell lung cancer within the greater scheme of neuroendocrine carcinomas, small cell lung cancer forms the vast majority of these, more than 9 in 10 patients with this histology. This is really why a lot of the data that's used to in the management of neuroendocrine carcinoma comes from small cell lung cancer. But when we're talking extrapulmonary, this is relatively evenly split in their primary sites between gastrointestinal, other, or unknown primary. When we're talking specifically gastrointestinal, colon is actually very well represented, pancreas, stomach, esophagus, rectum. Whereas in other sites, really this is dominated by the male and female genital tract as well as the urinary tract, bladder especially being well represented. In terms of male genital tract, prostate, and then female ovarian and uterine as well. But really most anywhere in the body. And important to note that 1/3 of extrapulmonary neuroendocrine carcinomas are of unknown primary. When talking about the clinical presentation and specifically tumor functionality, grade 3 neuroendocrine tumors may be functional or hormone producing, inclusive of the carcinoid syndrome, especially when we're looking at small intestine neuroendocrine tumors, but also lung, other primary sites. The classic teaching is that virtually all neuroendocrine carcinomas are non-functional. However, paraneoplastics can and often are seen. This is especially the case in terms of pulmonary disease, but really can be seen across the spectrum of neuroendocrine carcinomas. And in the clinic, this is something that I've seen with some very interesting paraneoplastic syndromes developing. The majority of both neuroendocrine carcinomas and grade 3 neuroendocrine tumors are metastatic at diagnosis. And interestingly, kind of in looking at the biology of these diseases, the incidence of brain metastases is significantly lower in neuroendocrine carcinomas compared to small cell lung cancer, which is, and it's much lower in grade 3 neuroendocrine tumors. So much so that if a patient with a grade 3 neuroendocrine tumor develops a brain metastasis, there's at least some question about the histology of the disease at that point in time. Going into the pathology and imaging and really focusing on grade 3 neuroendocrine tumors and neuroendocrine carcinomas here. So the important differentiating feature histologically is the presence of necrosis, the loss of cellular architecture. This really pushes towards a poorly differentiated neuroendocrine carcinoma histology, whereas that maintenance of cellular architecture and the lack of necrosis is much more consistent with neuroendocrine tumor. In terms of the Chi-67 index, grade 3 by definition greater than 20%. There's no longer any definition in terms of the Chi-67 index for neuroendocrine carcinoma. The vast majority have a Chi-67 index greater than 55%. We do see patients with Chi-67 index significantly lower than that, but poorly differentiated histology. Those can present certain challenges, but they are rare in and of themselves. And then in looking at the somatostatin receptor expression, so as many of you know, this is a little bit on a spectrum where the more well-differentiated grade 1, grade 2 neuroendocrine tumors are typically thought to be higher expressors of the somatostatin receptor. It becomes a little bit more heterogeneous in terms of grade 3 neuroendocrine tumors, neuroendocrine carcinomas. It's rare, but not unheard of expressing somatostatin receptor in a homogeneous manner specifically. Whereas the inverse is true in terms of FDG PET avidity or glucose uptake, metabolic activity of these tumors, tends to be higher than in grade 1 and grade 2 neuroendocrine tumors for grade 3, but really typically very high in poorly differentiated neuroendocrine carcinoma, which is very metabolically active tumors. Now, this is a little bit oversimplified. There can be a great deal of heterogeneity. Patients can be positive on both imaging, positive on one, not the other, negative on both. But this is the general scheme that we're dealing with. Going into the molecular pathology, this is something that I really try to drill into the minds of when I'm with fellows or seeing new patients. NGS is really critical in all patients with a grade 3 neuroendocrine tumor, as well as patients with neuroendocrine carcinomas. Unlike what is classically thought of in grade 1 and grade 1 neuroendocrine tumors, which are really genetically bland, we do find genetic aberrations, some of which may be actionable. This was a really great poster presented GI ASCO by Farha and al. looking at 45 patients, 20 of which had neuroendocrine carcinomas, 25 of which had neuroendocrine tumors, the vast majority of which were grade 3 neuroendocrine tumors, and looking at the mutations detected both by primary site and by tumor classification. So really what you can see is large number of patients with genetic aberrations across primary sites, colorectal, primary, small bowel, unknown. Um, it's always a little bit questionable if biliary neuroendocrine tumor exists or not. That's another area of controversy. But what you're seeing is a lot of TP53 mutations, RB1, um, ATRX, DEX, as well as potentially actionable mutations such as RET. Other studies have reported, oh, and sorry, going into the tumor classification, I'll discuss this more in the next slide, but TP53 and RB1 very frequently seen in neuroendocrine carcinomas, whereas DEX, MEN1, ATRX, I classically think of being more neuroendocrine tumor related mutations rather than neuroendocrine carcinoma. Other studies have reported deficient DNA mismatch rapport in up to 5% correlating with MSI high status. I have several patients with that I've seen with this respond incredibly well to immunotherapy, so very important data to obtain on all patients. And then it's been reported that BRAF is mutated in up to 50% of colon neuroendocrine carcinomas. Again, allowing for potential actionable pathway there, especially with the high prevalence of BRAF V600E mutations, and now previously considering treatment with encorafenib and cetuximab, and now with the tumor agnostic approval of dabrafenib, trametinib in this patient population. I've had a lot of success treating patients with that as well. So another important role of molecular pathology are for those that's been developing and discussed at most recent NANETS and GIASCO last year, is the role of molecular pathology for differentiating some of these difficult histologic cases of neuroendocrine carcinoma versus grade 3 neuroendocrine tumors. So this is from a study published in Endocrine-Related Cancer 2021, looking at mutations expressed in neuroendocrine carcinomas versus neuroendocrine tumors grade 3. And what you really see is that TP53 RB1 mutations are really expression is higher in the neuroendocrine carcinoma group rather than neuroendocrine tumor groups, whereas there's other mutations looking specifically at DEX, MEN1, ATRX, where it's much more expressed in neuroendocrine tumors rather than neuroendocrine carcinoma. This is a pathologic algorithm. It's actually older, from 2016, but this data now kind of supports even more the idea of those cases where it's difficult to differentiate between a poorly differentiated neuroendocrine carcinoma and a well-differentiated neuroendocrine tumor grade 3 that prognostically and predictively the expression of these mutations, P53, RB1 predicts more of a neuroendocrine carcinoma phenotype, whereas DEX or ATRX or MEN1 predicts more of a neuroendocrine tumor phenotype and can be helpful in that regards as well. Jumping now into the management specifically of neuroendocrine carcinomas. So this is an algorithm that I adapted from the up-to-date algorithm for neuroendocrine carcinoma. And I just want to put it here because it's really important to consider whether patients have localized local regional disease versus local regionally advanced versus metastatic. I think sometimes that what happens oftentimes is patients get a diagnosis of neuroendocrine carcinoma and they're automatically put in this box of it's chemotherapy, it's systemic therapy. But just like all neuroendocrine tumors, these patients really need like a multidisciplinary approach to their care. And specifically in patients with localized or local regional disease, surgery can play a role and should play a role in certain situations. This is excluding esophageal because actually esophageal, there's data to support that in neuroendocrine carcinoma histology. Surgery leads to worse outcomes compared to chemoradiation plus systemic chemotherapy. But again, in local regionally advanced disease, the consideration of chemotherapy plus chemoradiation or radiation. Now, There is also a role potentially for trimodality therapy, so chemotherapy, surgery, and radiation or chemoradiation in certain high-risk cases. But for the vast majority of patients with metastatic disease, we're talking about systemic therapy, chemotherapy. Mastectomy is very controversial in this. It can be considered, but really on a case-by-case basis. So jumping in specifically to this question about is there a role for surgery in localized neuroendocrine carcinoma? Yes, it is likely a systemic disease, and yes, all of these patients do need systemic chemotherapy, but retrospective reviews have supported a potential role for resection in non-metastatic, non-esophageal neuroendocrine carcinomas. This was a really great retrospective review published in Surgery in 2021, looking at patients between 2000 and 2012 with non-metastatic, poorly differentiated gastroenteropancreatic neuroendocrine this should be a neuroendocrine carcinoma. And looking at those patients who underwent resection versus those patients who didn't go resection, and the 5-year survival was 39% after surgery, whereas it was 10% or approaching more what we're used to seeing in terms of numbers for neuroendocrine carcinoma in the non-operative group. Just like any surgical study, there is some inherent bias in terms of which patients were healthy enough to undergo surgery. Was there biologically a difference in those patients who who underwent surgery versus not? But it is to say that if surgery is feasible, patients can have sort of long-term benefit in addition to systemic chemotherapy. Now, talking about systemic therapy specifically, it remains platinum and etoposide. It's hasn't changed for a long time. It remains the mainstay of first-line systemic therapy, and the question always comes up of which platinum to use, cisplatin versus carboplatin. Classically, we use cisplatin in patients who are younger, fitter, that we're less concerned about some of the toxicity, neurotoxicity, renal toxicity, etc. Whereas carboplatin oftentimes we'll use in less fit patients who were less confident about their ability to tolerate chemotherapy, has more hematologic toxicity, but overall better tolerated. This was a retrospective analysis looking at overall survival in patients treated with carboplatin versus cisplatin in addition to etoposide that showed a potential benefit in terms of survival in the cisplatin-based regimens. But even in their study, they recognize that the comorbidity is a potential major confounder for this study, whereas we know that performance status predicts survival in neuroendocrine carcinoma treatment. So this wasn't controlled for underlying comorbidity. So as of right now, still not clear whether one is better. Just by practice, we think cisplatin, if either of them has an advantage, it's cisplatin. So for patients who can't tolerate it, we're trying to use cisplatin with etoposide. What about the question of the addition of an immune checkpoint inhibitor similar to small cell lung cancer? Really, right now, there's no data in neuroendocrine carcinoma for the addition of immunotherapy to upfront chemotherapy. And one of my concerns is oftentimes this is done out in the community, and then it burns a little bit of a bridge where we don't know if it's actually beneficial in the first line, but then it makes it more difficult to use chemo or immunotherapy options in the second plus line settings as well. But this is the subject of an ongoing cooperative group study, which I'll discuss more in just a moment. When we're talking about second plus line therapies, there's a fair number of options. It's actually very reasonable to retreat patients who have had a very good response to platinum and etoposide. Can also consider utilizing a different platinum agent if cisplatin was used and carboplatin being used in the future. There is one of the very rare prospective studies was recently terminated due to futility, but nonetheless, important study comparing FOLFIRI versus capecitabine and temozolomide in the second line setting, both of which showed activity, both of which were tolerable, and I think both of which are good options in the second plus line setting. FOLFOX, I don't use very much FOLFIRINOX in these patients. Again, when we're talking more about a palliative intent, it's maximizing our lines of therapies. Immunotherapy, pembrolizumab for MSI high or TMB high tumors have had a really tremendous success in those rare patients, but otherwise Nivo Ipi in across all patients in the second line setting. Rare responses, but in those patients where you do get responses, sometimes they can be maintained for a prolonged period of time. And then targeted therapies, really important, again, NGS on all these patients. Dabrafenib, trametinib for BRAF V600E mutation positive, RET mutation fusion positive, selpercatinib. But I have yet to see an NTRK mutated. I'm sure they exist, neuroendocrine carcinoma, but entrectinib, larotrectinib are very reasonable options. If there's a targeted therapy option available to me, those are typically my second line before utilizing other chemotherapies. What about the role of PRRT in neuroendocrine carcinoma? So very little data, and this would be an extraordinarily difficult trial to conduct just because of the rarity of neuroendocrine carcinoma. And most patients do not undergo dotatate imaging, but kind of in the early days of Lutathera PRRT studies, there were some patients who were still being classified as neuroendocrine grade 3, who then in retrospect could be segregated out as neuroendocrine tumor grade 3 versus neuroendocrine carcinoma, who did receive PRRT. Now we're talking very small patients in retrospective, but looking at the response rates, their response rates 40% or so. Again, only in patients with dotatate avid disease, somatostatin receptor expression. The progression-free survival, not great when you're looking specifically at neuroendocrine carcinomas, the vast majority having a high Ki-67 index. But if you do compare it to second-line chemotherapy, it actually compares relatively favorably. I will say this is nothing more than hypothesis generating at this point, and potentially considered when all lines are off. There's no further treatment options, and you have a patient who happens to have dotatate avid disease. I have one or two patients where I've considered it, but this is a rarity, and it would be a very difficult trial to do. Though there is, in small cell lung cancer, there's currently a trial looking at the addition of PRRT in the first line setting in those patients. So again, we could gather inspiration in the future from small cell lung cancer. In terms of first-line clinical trials that are ongoing, I mentioned this SWOG S2 012 phase 2/3 trial of first-line platinum etoposide with or without atezo. Very important trial that could be potentially practice-changing. At GI ASCO this past year was the NABNEC trial that was presented, a phase 2 trial of Abraxane with carboplatin versus carboplatin and etoposide in the first-line setting for GI neuroendocrine carcinomas. Presented data, it did meet its objective response rate, primary endpoint, 53 versus 42%. No difference in PFS. There was a trend towards increased overall survival with this experimental regimen, but also a higher rate of grade 3 grade 3 or greater toxicity, 52% versus 42%. There's also a small study going on in France right now, FOLFIRINOX, looking at specifically, I believe, GEP neuroendocrine tumors, so gastroenteropancreatic, and FOLFIRINOX up front versus platinum and etoposide. When talking about sort of next line or emerging targets, it's really important and critical to mention DLL3. So delta-like ligand 3, it's an inhibitory ligand of the Notch receptor. This is a really important pathway in neuroendocrine carcinoma involved with the neuroendocrine differentiation, proliferation, metastasis. And this is, DLL3 is minimally expressed in normal tissues, but it's expressed in more than 3/4 of poorly differentiated gastroenteropancreatic neuroendocrine carcinomas. DLL3 expression has been correlated with RB1 loss, negative somatostatin receptor functional imaging, and an overall unfavorable clinical outcome. So this is giving us an exciting target, and as you can imagine, there are multiple trials that are looking at addressing this. So this is going on both in small cell lung cancer, where DLL3 expression is common, as well as neuroendocrine carcinomas. There is the ADCT-701 DLK1 targeted antibody drug conjugate. I believe that's at the NIH currently. In Bethesda, PT217 bispecific antibody targeting DLL3, as well as the T-cell CD47. There's another bispecific antibody looking at targeting DLL3 and CD3. This is both a first-line trial and combined with platinum with etoposide, and as well as monotherapy and subsequent line therapies. Other emerging targets, just to mention, it's really difficult. There's a lot of studies if you go into the phase 1 sort of tumor agnostic, but if you're looking specifically at neuroendocrine carcinoma specific trials, the list is much shorter. This may not be inclusive of all trials, but I tried to kind of go through and approach these. So there is a viral vector study, VSV, interferon beta, sodium iodine transporter, viral vector combined with pembrolizumab. This has 2 arms open for non-small cell lung cancer or neuroendocrine carcinoma, the arms 2 and 3. Phase 1/2 trial currently open at Mayo Clinic in Rochester, as well as in Cleveland Clinic, Ohio. And then at the NIH in Bethesda, looking specifically small cell lung cancer, neuroendocrine carcinoma, after kind of standard treatment options have been exhausted, the combination of lurbinectedin with berzosertib. Shifting gears into more the high-grade neuroendocrine tumor, grade 3 neuroendocrine tumors, the treatment approach here is really an evolution, or I would say minimally evolved from grade 1 and grade 2 neuroendocrine tumors, where the standard really is for patients with local regional disease and thus resectable disease. Upfront resection remains the standard recommendations. If it can come out, it should come out. Now, when we're dealing with local, regionally advanced, or unresectable disease, a lot of the things that we do for grade 1 and grade 2 remain on the table. Liver-directed therapy, when appropriate, chemotherapy we'll discuss a little bit more. And this is, again, from up to date, and this is actually becoming a little bit outdated, and I'll discuss why momentarily. So when we talk about the management of local regional disease, really extrapolated from grade 1 and grade 2 neuroendocrine tumor for the management of grade 3 disease, surgery, liver-directed therapies considered in patients with localized disease, as well as with patients with metastatic disease for control of hepatic disease burden. One of the big reasons that all this is just extrapolated from grade 1 and grade 2 is that it has not, the grade 3 neuroendocrine tumor as a disease entity hasn't really existed for long enough, but we should be getting more data to sort of guide grade 3 disease as time goes on, since these updates in 2019. Now, this is important because these grade 3 neuroendocrine tumors, even those patients who can undergo surgery, they behave differently. Compared to grade 1, grade 2 NETs, grade 3 neuroendocrine tumors are associated with increased recurrence risk after surgical resection and decreased overall survival. Many of you are familiar with the Zadie score, or I think it has a new name now. It's the recurrence index. I forget what exactly it is, but this was looking specifically at pancreas neuroendocrine tumors and trying to do a multivariate analysis to find predictors of disease recurrence. What you can see is statistically significant is after multivariate analysis in terms of odds ratios, symptomatic disease, tumor size, and lymph node positivity. But the big one here is really the Chi-67 index with greater than 20%, or that's grade 3 disease. The odds ratio being almost more than, well, several of these combined. Odds ratio of 6.7 versus most of these are under 2. Now, with this knowledge of a high risk of disease recurrence, it's also changing our paradigm a little bit about the use of adjuvant therapy. Now, adjuvant therapy currently does not play a role for neuroendocrine tumors as a whole. Historically, that was in part because of the poor tolerability of the chemotherapy options that we did have and also their lack of efficacy. But since capecitabine and temozolomide has been demonstrated to have really significant efficacy in pancreas neuroendocrine tumors, the high risk of recurrence of these neuroendocrine tumors, as well as the efficacy of this chemotherapy, form the basis of this currently open SWOG cooperative group study of phase 2 trial of postoperative adjuvant capecitabine and temozolomide versus observation in high-risk pancreas neuroendocrine tumors. This is looking specifically at grade 2 and 3 pancreas neuroendocrine tumors, high risk by Zaidi score. As you can see, the grade 3 neuroendocrine tumors automatically qualify just based on their risk. And status post R0 or R1 resection, 2-to-1 randomization, 4 cycles of CAP-10 versus observation. This study has been open, I think, for about a year and a half. It's about a third accrued based on the website as of 2 days ago or so, but really a critical trial that I really encourage patients to participate in, and providers. We have this open at OHSU, and anywhere where this question comes up, I think it's a really good option for patients to participate. When looking at chemotherapy for grade 3 neuroendocrine tumors, and I'm specifically talking about non-pancreatic in this regard, there's a little bit of a conundrum here in that platinum etoposide specifically, if you treat patients with neuroendocrine carcinomas or neuroendocrine tumors grade 3, since they were grouped together previously, what you see is that response rates for neuroendocrine tumors are far lower than they are for neuroendocrine carcinoma. But if you look at the overall survival, it's uncomparably better for neuroendocrine tumor grade 3 versus neuroendocrine carcinoma. So even though response rates to platinum and etoposide are much higher in neuroendocrine carcinoma versus grade 3 neuroendocrine tumor, the significantly favorable overall survival in grade 3 NET really favors the use of more tolerable chemotherapy regimens that lead to disease stability rather than looking for necessarily a response. Again, excluding pancreas neuroendocrine tumors from this topic here, but I tend to use a lot more CAP-10, even sometimes FOLFOX in this situation, and much less platinum etoposide, unless they have very aggressive disease and we are really striving for a response as quickly as possible. In terms of other systemic treatment options for grade 3 neuroendocrine tumors, until recently there was very little data to guide the use of other agents in grade 3 neuroendocrine tumors. Again, everolimus and sunitinib use extrapolated from grade 1, grade 2 data. But this has really changed, and the paradigm has changed since NETTer-2 was presented at GI ASCO this year and just very recently published in The Lancet. So this study is really, in my mind, practice changing for the treatment of first-line grade 3 neuroendocrine tumors. This was a randomized phase 3 trial comparing lutetium dotatate, Lutathera, every 8 weeks times 4 plus octreotide, standard dose 30 milligrams every 4 weeks, versus high-dose octreotide 60 milligrams LAR every 4 weeks. The key inclusion criteria, newly diagnosed, so first-line therapy, grade 2 and grade 3, somatostatin receptor positive, GEP-NETs, Ki-67 index 10 to 55%. I think this is an important thing to look at. The Ki-67 index is that it is looking at sort of part of grade 2 and grade 3, and we'll talk about that more in a minute. Randomization, just standard randomization scheme for NETTer-2 that they published in the Lancet here. But I think what's really important to note here is when you look specifically at grade 3 disease, this is the first prospective study that includes really a clinically useful number of grade 3 patients, 79. 52 of which received Lutathera, 27 of which received high-dose octreotide. So this is really the first study that we feel comfortable is treating grade 3 disease. As you all know, NETTER-2 met its primary endpoint with Lutathera significantly improving progression-free survival versus high-dose octreotide. Amazingly, some complete responses were seen, which really is generally thought to be very rare in neuroendocrine tumors. But disease control rates were upwards of 90%, very few progressive diseases. So this is telling us that Lutathera is really a good option for patients with unresectable or not feasibly resectable disease in the first line setting. But I think there's more to this study than just saying that Lutathera is a good treatment option. And specifically, I think that high dose octreotide actually proved its merits as well. If you look, I mean, these are patients with high grade 2 or grade 3 disease. More than half, I mean, 60, 65% actually had some disease control. Most of it was stable disease. But there even were some responses to high dose octreotide, which we wouldn't have necessarily expected. And so what this is telling me is that not only do we have Lutathera in the first line setting, but putting patients even potentially on high dose octreotide is not an unreasonable treatment option. And we probably have more data supporting that than we have for a lot of the other treatments that we offer patients at this time. Again, for somatostatin receptor positive disease. This is the subgroup analysis that you want for all of your trials, but that you never get, where across all subgroups, there was benefit, grade 2, grade 3, pancreas, non-pancreas, just everyone really benefited from Lutathera. And we'll be getting more granular data as time goes on, hopefully, as well. Looking at the adverse events, so not unexpectedly across all grades, similar Lutathera versus high-dose octreotide. When you start talking about grade 3, higher in the Lutathera arm versus high-dose octreotide, but still generally tolerable. If you're looking at adverse events of special interest, namely hematologic toxicities, significantly higher, of course, in Lutathera. Big one of concern being thrombocytopenia in my mind, and the persistent thrombocytopenia that we deal with that can be treatment limiting in the future, unfortunately. Data is really not mature enough to discuss secondary hematologic malignancies, but again, as time goes on, that's still be coming out. And of course, very little in terms of nephrotoxicity and very little in terms of these toxicities seen with high-dose octreotide. So both tolerable regimens. So now we're kind of revisiting this evolution of the neuroendocrine neoplasm classification. I talked about going from 2010 to 2019, and now we're in 2024. From sort of clinical experience, anecdote, and people who, those of us who treat neuroendocrine tumors will tell you that grade 2 disease, someone with a Chi-67 index of 19% is not the same disease as a patient with a Chi-6, their tumor with a Chi-67 index is 3.5%, even though they fall into this grade 2 category. Now, even though we sort of knew this in our gut, we didn't have a lot of data to support this, but it is kind of just as it was for NETTER-2, this is kind of going into a little bit of our practice considerations. But now, just recently, kind of hot off the press, published in Annals of Surgical Oncology, we do start having some data to support that there is a differentiation between this grade 2A Chi-67 index less than 10%, grade 2B 10 to 20% disease. And that specifically if you're looking at clinical pathologic features of aggressiveness and kind of a multivariate analysis of figuring out the predictors here. Grade 2B disease and grade 3 disease look a lot more similar in terms of their rate of liver or distant metastatic disease versus this kind of grade 2A group and grade 1, which are a little bit more similar, seem to be more indolent. So perhaps how we are splitting this disease still needs to evolve. This is from the same study and kind of, again, doing a multivariate analysis, looking at the risk of adverse outcome defined here as liver, distant metastasis, or disease-related death. Even though patient numbers are small, what you do see is kind of this clear trend towards grade 1, grade 2 being rather similar in terms of their risk of this adverse outcome, whereas grade 2B and grade 3, again, small patient numbers, but the risk goes significantly higher in these categories. So this is already being incorporated to a certain extent in other trial designs. This is the composed clinical trial that's currently open, comparing a different form of PRRT, lutetium edotrietide, versus best standard of care in aggressive GEP-NETs. Randomized phase 3 trial comparing lutetium edotrietide versus investigator's choice capecitabine and temozolomide versus or FOLFOX or everolimus. This is an advanced PRRT naive SSTR grade 2-3 GEP-NETs, Chi67 index 50 to 55%. This use of 15% is a little bit arbitrary, but again, trying to get to the fact that higher grade 2s seem to behave differently. Primary endpoint of PFS, this is a multinational study. I believe it's probably like 3/4 accrued at this point, though I don't remember the exact numbers. Not a lot of trials going on right now that are specific to grade 3 NET, but inclusive of grade 3 neuroendocrine tumors are multiple. One is sort of next generation alpha PRRT using lead-based 212 lead VMT, grade 1 through 3 somatostatin receptor positive neuroendocrine tumor. The other Raise Bio is in grade 1 and 2, I believe. There's an important cooperative group study looking at pancreas neuroendocrine tumors, CAPTEM versus lutetium dotatate. There's actually a CAR T trial ongoing targeting cadherin 17, grade 1 through 3 GEP-NETs at Sarah Cannon in Tennessee. And then at Washington University, Missouri, the use of cabozantinib in neuroendocrine tumors and neuroendocrine carcinoma, Chi67 index greater than 20%. So in conclusion here, classifications of NETs and neuroendocrine carcinomas continues to evolve as we better understand the biology of this disease. And the management of both neuroendocrine tumors and neuroendocrine carcinomas is really complex and does require multidisciplinary evaluation. I really want to make this point, especially for neuroendocrine carcinomas, is that it's not the sort of one-size-fits-all treatment, systemic treatment for everybody. Systemic treatment for both localized grade 3 NETs and NECs is evolving. Clinical translational research is very difficult in these diseases because of their rarity, but as this is an underserved population and really critically important to involve patients in these research studies to hopefully improve outcomes overall. So thank you for having me to discuss this topic today. Want to say thank you to our whole neuroendocrine tumor program that is growing at OHSU, our GI oncology clinical team, the research team, the gastrointestinal surgery team, and of course, all of our patients and their families. Happy to take any questions.
Thank you so much, Dr. Pegna, for that fantastic presentation. At this time, I want to open the floor for any potential questions anyone might have. Feel free to write it in the chat or unmute and ask a question.
So when you were talking earlier about potential targeted therapies, I noticed that KRAS was present for NECs. Are those in particular those in the 12th codon in 12th and 13th codon of KRAS? And has there been any research into taking current targeted KRAS treatments and using them in NECs?
That's a great question. I think I tried to minimize my screen and I may have just closed it altogether. But I'm trying to go back to the study here. I don't believe that KRAS targeted agents have been, and I don't have the data specifically for G12C, G12D otherwise, but as these agents do come out, that it's, I think it's a very reasonable thing to evaluate. Now, just like in colon cancer, where the limited data that we have, like sotorasib by itself, is not really terribly effective, but perhaps in combination with, well, the recent approval is with EGFR inhibitor plus sotorasib. That may be a reasonable approach, but it will be evolving. And I think as we sort of subtype these disease more, that will give us more, kind of like the way that gastric cancer has gone, where we're really sort of learning that it's a bunch of subtype of diseases, and the treatment needs to be tailored to that disease.
Thank you. And I think it's cetuximab that's been approved with sotorasib, if I remember
Sotorasib, yeah,
correctly.
it's cetuximab, yeah, just recently, like a week ago.
Wonderful. I have a brief question. This is really for Dr. Pegna, and really anyone can chime in. So I've historically studied Notch signaling, and I am absolutely fascinated by the role of Notch signaling in these high-grade, poorly differentiated neuroendocrine tumors. But the issue that I always run into on the research side of things is people tell me, well, it's a rare disease. There's not enough patients, to get funded in. And it's been really difficult for me because I've written several proposals. I'm like, I really want to look into this. I think it's very important. I think, there's so much to be learned about the biology of this disease, but yet it's so rare, I can't capture anyone's interest. What are your thoughts on that? Or what are anyone's thoughts of how to rally interest to look into these diseases more?
Yeah, I will in part refer you to my mentor who's on, Dr. Del Rivero, because I think she'd be a great person to ask. But I will say that I think a reasonable approach is what's been done with a lot of these is to sort of capture a larger population as you're looking to get your subpopulation. So small cell lung cancer, because it's so much more prevalent, studies that are involving small cell lung cancer plus neuroendocrine carcinoma, it's a way of sort of like
Piggybacking.
capturing exactly
Yeah.
piggybacking on that. Dr. Del Rivero I feel, and not to put you on the spots, but you may have some good ideas as well.
Yeah, I like that idea. I didn't really think about that, especially in terms of research and grants. Instead of just specifically saying, oh, I'm going to study this in this rare cancer type, I put that as part of a whole. That
Yeah.
definitely makes sense and is very doable. There's plenty of small cell lung cancer. There's a lot more tools and techniques to study that cancer that then can be applied to the high-grade poorly differentiated neuroendocrine carcinomas.
Absolutely.
Thank you. Does anyone else have any questions at this time?
One more molecular question. You mentioned earlier that you were seeing MSI high in many of the tumors. Do you what about DMMR? Is that noted in NECs at all or no?
DNM, like mismatch repair deficiency, or?
Yes.
Yeah, it's we see that specifically on IHC, which oftentimes is enough to like guide the use of immunotherapy. It's more, all of these patients end up getting NGS as well, so then you have sort of data. There's a 95 or 96% concurrence rate between mismatch repair deficiency and MSI high status, and usually the lack of concurrence is in when you have mismatch repair proficient with MSI high disease, so you catch them on the back end.
Interesting.
Yeah.
All right.
But yeah, it's I've had fantastic responses to immunotherapy. Again, N is low, but 3 to 4 patients with MSI high disease, and one lady had underwent like an emergency surgery because of like obstruction from a small bowel neuroendocrine carcinoma, had positive margins, residual disease. I've known her as long as I've been here at OHSU pretty much, and she's doing extraordinarily well with no evidence of disease. So.
That's great to hear.
Yeah. All right. Well, if we don't have any more questions, then we can go ahead and wrap up. And so I just want to say thank you again, Dr. Pegna, for speaking to us today. And thank you to everyone in the audience for taking time to tune in. We are very grateful. And we will be back at the end of August next month for our next NETChatter event. So I look forward to seeing everyone then. So thank you all again and enjoy the rest of your day, morning, or night.
Thank you so much for having me.